Thank you for the kind introduction. I'm wondering if I could ask Dr. Haber to first present just briefly about the program that we have here at Massachusetts General Hospital. I'd like to share my screen just so I can put my slides up. And should I turn on my video, or is it better to leave the video off?
You can turn it on, that's okay.
Okay, I'll see if I can do that. Yeah, I'm unable to put on my video, but oh, there we are.
You're
All right.
on.
Hi, everyone. Good afternoon. So I'm going to start the slideshow so Jessica can present, and then I'll take over from Jessica after she's finished her piece.
Wonderful. Well, good afternoon, everyone. And thank you so much for this opportunity to join your group. I see we have a very robust membership here. And so it's fantastic to get to have this opportunity with you today. And I just wanted to steal maybe 3 or 4 minutes before Dr. Babel starts to tell you how we came about joining you. And this is through a program at the Massachusetts General Hospital called the Anne Kablansky Visiting Scholar Award. And the main reason I want to share it with you is because I think it's a fantastic opportunity for many, specifically women faculty, to help advance their careers. It's what brought Dr. Babel to you, so I wanted to tell you a little bit more about it. Lisa, can you advance? Sure. So Anne Kablansky is an endocrinologist at our hospital, which is called Mass General Brigham. It's a combination of a few hospitals. Lisa, if you wouldn't mind advancing. We're actually the largest hospital-based research enterprise in the United States with annual funding of over $2 billion. So this is a very large enterprise based in Boston with many hospitals for routine clinical care as well as for research. Next slide. And this program was developed during the pandemic when I think many people were worried about career development, and in particular, having opportunities to speak and to advance careers, which disproportionately I think is challenging for women, particularly with other responsibilities, and maybe not having the sponsorship that is really necessary to advance careers. And so this program was developed specifically to help with giving talks, networking, doing the things that we need to in academia. And is presented every year to about 30 to 40 scholars, all women faculty with exceptional promise as future leaders, and whose careers could benefit from speaking to new groups, either nationally in the US or internationally, as we're doing here today. Next slide. So this program involves several components, including sponsorship from senior faculty, a champion, if you will, which is what the role that I'm playing here today. But the scholars also receive individual sessions with an executive coach, group sessions with the other scholars, skills in learning how to give presentations, and whatever professional development skills they may need. And there's an article published to give you more details in case you're interested by Miriam Burdella, as you can see in the citation in the bottom. Next slide. So I hope you'll see this is a very low cost, lean and mean sort of program that has a lot of impact. It creates these opportunities for exchanging ideas, particularly among female scholars, although I think this program could apply to anybody who needs advancement in their career, as most of us do. And it's readily applicable in any setting. I'm very thankful to Dr. Nellie Mugo, who connected us with your group today. She's a longtime colleague of mine, and it's just wonderful to be able to bridge this network and bring Dr. Babel to you today. So one last slide. And just to summarize the impact of this program, one of my colleagues, Dr. Scott Vernalia, said, she was a scholar herself, said that this program gives space for faculty to hone their brand, to take time to think about ways to expand their reach and impact, and bring community with other amazing women faculty. And I think you'll see that that should be our experience this afternoon. And with that, I'll turn it back over to you, Dr. Babel. And here, feel free to jot down my email. I'm always happy to talk about career development with this program and otherwise. Thank you.
Thank you, Dr. Haber, for that very helpful introduction to the program. I'm delighted to be an Anne Kablansky Scholar. I feel very fortunate to have this opportunity to speak with you today. So once again, good afternoon, and thank you again to the organizers for inviting me to present to you on this topic. I look forward to taking your questions at the end of this and having a robust discussion. I think I'll be speaking for around an hour, and then we should have time at the end for some discussion and question and answer. So the goal of today's talk is to review a bit about the placenta. So the placenta is something we don't actually talk about a lot, despite most of us being medical practitioners here. And we'll talk about the role of the placenta in pregnancy and child health. We'll review the anatomy and the current state of research. And because I'm an infectious diseases physician, I'll focus more on maternal infections and their impact. I have no relevant financial disclosures to this talk. I'm also not an obstetrician, so that is my other disclosure. My understanding of the placenta and the way that we'll talk about it today is really through the lens of being an infectious diseases practitioner. I also practice critical care medicine, as was said in the introduction. And so I'll be talking about it mostly through a non-obstetrician lens, and I'll really look forward to a robust discussion from many of you who are maternal fetal medicine specialists and other experts. So this is the outline for what we'll discuss today. So we'll talk about the placenta in pregnancy, its importance, its role, structure, and function. I'll give you a brief overview of placental disorders just to review the things that can go wrong. And then we'll talk about a concept that I think is really important and has really influenced and guided our research on the placenta, which is a concept called the developmental origins of health and disease. We'll talk about what that means, how it applies to the placenta, and especially with respect to infections and inflammation. We'll talk a little bit about some of the maternal infections that are important for both maternal outcomes and child health outcomes. Some placental research that's ongoing generally. We won't talk much about our own research today, but maybe in a future webinar. And then I'll give you some ideas of what you can tell your patients, for those of you that work with patients, to help them get the best outcomes out of their pregnancy and start their children off with the healthiest life. And then we'll go through a summary and conclusions, and we'll take questions and discussion at the end. So thank you again for being here. I'll also put up my email address at the end. You can contact the organizers. If you have to leave early, please feel free to contact me. I'd love to hear from you. All right, so let's talk a little bit about the placenta. So this is a diagram showing you in the pregnant person where the placenta generally lies and its relationship to the baby. So what's so fascinating about the placenta and really got me interested in studying in the first place is that the placenta is an organ, but a temporary one. And there's really nothing like it. We don't have organs that develop and get discarded. So it's pretty cool that the placenta exists. And it's also an amazing partnership. There's a fetal component and a maternal component. This is also part of what makes the placenta a very potentially challenging organ from a physiological and an immunological perspective, because there are two components. The fetal component grows into the maternal component, and the fetal components consist of the placental disc itself, so that actual piece of the placenta that we usually witness when we see it physically, the amniotic and the chorionic membranes, which are together called the fetal membranes, and the umbilical cord. Those are all produced by the fetus. And the maternal component is the decidua, which is derived from maternal endometrium. So it really comes from the uterus and extends into the placenta. And so those two pieces, the fetal side and maternal side, join, and then they have to develop a shared blood flow to get the fetus what it needs during pregnancy to develop. What's also interesting about this is that the placenta is largely, in terms of just the bulk weight, a fetal organ. And so when you think about it, it's not all self. So it doesn't all come from the mother. And so it's a very interesting concept immunologically. How is it that the placenta can stay there for the duration of pregnancy and not be rejected? So that leads to a lot of really interesting immunological questions and questions around infectious disease, because there's a tolerance that has to develop to the placenta to allow the pregnancy to continue without rejection, without early delivery. So it's actually amazing that it works so well most of the time. So that's a very high-level view. Let's talk a little bit about how the placenta is formed. So this diagram on the right just gives you a sense of the different components of the placenta and how they form over time. So I'm not going to talk about implantation or trophoblast differentiation. Those happen very early and they're not really pictured here in the diagram. But once the placenta, the blastocyst does implant in the wall of the uterus, and the trophoblasts differentiate into the cytotrophoblast and the syncytiotrophoblasts, those two cell layers then do the work of forming the placenta. So the syncytiotrophoblast starts to invade into the uterine lining. So that's what's depicted here on the right side of the screen. So the syncytiotrophoblasts are here, and they're starting to invade into the uterine lining to start to form these spiral arteries that then develop the blood flow, the exchange that happens between the mother and the baby. So the chorionic villi also develop from the trophoblast, and they extend into these maternal spaces, which are filled with blood. And that's ultimately how the fetus is going to access the nutrients that it needs, the transport to remove waste from the fetal space, and all of the other exchange components that the placenta provides. The placenta circulation develops fetal umbilical arteries and vein, which grow into the chorionic villi, and the placenta forms layers. So the amnion, which is the inner layer, the chorion, which is the outer layer of those two fetal membranes, which then appear sealed when we see the placenta in real life after delivery. The placenta also has a really important function in producing hormones that maintain pregnancy. So these hormones basically allow the placenta to grow, and they make changes in the physiology of the pregnant person. The placenta then matures, it grows and adapts over the duration of pregnancy and provides these important functions, all the nutrients the fetus needs, the oxygen, and the immune protection, as we discussed. So what are those key functions? So nutrient transfer, obviously the nutrients that are needed for fetal growth, oxygen exchange, all of the oxygen that the fetus needs to grow and form organs and develop normally, removing the waste products that are produced. The fetus has metabolism just as our muscles and organs do, and there needs to be a mechanism to remove those waste products so they don't build up and become toxic. It does produce these vital pregnancy hormones, which maintain the state of pregnancy, and they're the ones that we detect in a pregnancy test. It shields the fetus from infections, which we'll be talking about a lot today, what that role is and how that works. And it also maintains a fluid balance. So amniotic fluid, which is the fluid that's inside of the membranes in the uterus, maintained by this exchange. Also stabilizes fetal temperature and metabolizes drugs. So this is also important when we think about it from a research perspective, how that drug exchange is regulated and which drugs, maternal drugs, might concentrate in the fetus and the placenta, which don't access the fetus and placenta, and that has important implications for safety. So thinking about the placental circulation on a deeper level, this is a diagram of a cross-section of the placenta. So at the top is the umbilical cord as if it were going towards the baby. At the bottom is the bottom of the placenta where it would interact with the uterine wall. So this is supposed to give you an indication of what the placenta would look like if you cut across it, showing the fetal part on top, the space where the two interact, the maternal and fetal part, and the maternal part on the bottom. So what you can see here is a diagram showing the umbilical artery, which is here in blue, and the umbilical vein, which is here in red. And what's confusing about the placenta is that actually in the placenta, the artery carries deoxygenated blood. So that's fetal blood that's coming from the fetus. It's been used up of its oxygen, and it goes back into the placenta, and it goes into a villus tree, which is like a capillary bed, just if you imagine the capillaries that adults or children, humans have. And it goes back through these umbilical arteries, and it interacts with oxygenated blood that's coming from the maternal circulation, which is shown here in red. And that oxygenated blood, just like would happen in the lungs, and the tissue in the lungs, goes back to the fetus. So that exchange is obviously critically important, and it happens here in the villi. So when we talk about research on the placenta, one of the important things that we really want to look at is how the villus tree is forming, how the vasculature of the placenta is forming, how that can be affected by maternal infections, drugs, and inflammation, because this is really where the magic happens. This is where it's critical that both oxygen exchange occurs and also the exchange of nutrients and waste. Let's talk a little bit about the placenta as a barrier. So I mentioned that placenta functions to protect the fetus from infections that could occur. So the placenta basically is the interface between the maternal and fetal circulation. And there are things in the maternal circulation that could be harmful to the fetus as well, especially if the mother were to get sick or have an infection. So it prevents direct contact with pathogens through a physical barrier, but there's also several other mechanisms, and I'll go through some of these in more detail, that protect the fetus in other ways. So I don't know if you remember from your schooling, but there are tight junctions that actually are really close approximations between cells that also provide a physical protection between the placental cells, limiting the passage of microorganisms. So most of those tight junctions are actually so close that physical passage is not possible. The bacteria are too large to fit through, and even some large molecules. There's also a whole host of specialized immune cells that are present in the placenta, especially placental macrophages called Hofbauer cells, which engulf and neutralize pathogens. And they live there, and their job is to protect the fetus. The placenta also produces a whole cadre of antimicrobial proteins. So these are molecules that actually are antibacterial or antipathogenic that directly kill or inhibit their growth. And of course, the placenta transfers antibodies between the maternal circulation and the fetus. And so that passive antibody transfer, which occurs throughout pregnancy and accelerates over time, protects the fetus and the child when the child is born from infection early in life. There is a budding fetal immune system, but that takes time to develop and become effective. And then there's a placenta membrane itself, which allows nutrients and oxygen to pass while blocking other harmful substances like toxins. It's basically a filter. And the umbilical cord, interestingly, also has thick muscle layer that can contract and somehow prevent infections from the placenta to the fetus. Lastly, the amniotic fluid itself is kind of like living in a bubble. It's a protective buffer against external pathogens. It's technically sterile and it has antimicrobial properties, the liquid in that environment. So it's kind of amazing, these different layers of protection that exist, each of which plays an interesting role in protecting the fetus and deserves its own attention in terms of research. So let's talk a little bit about placental disorders. As I mentioned, I'm not an obstetrician, but there are many things, unfortunately, that can go wrong. The placenta is a complex organ, as I've just shown you, and problems with its formation and its function, or even its separation from the maternal circulation at the end of pregnancy, can lead to both maternal and child health issues. So I'll go through a brief overview of placental disorders, which is really not the focus of my research, but I think it's important that you understand what can happen. So there's a whole spectrum of disorders called placenta accreta, and I've shown a picture here on the top where it shows an abnormal adherence of placenta to the uterine wall. So you can see here in the normal version on the left, the placenta sticks inside of the uterine wall, but in the placenta accreta spectrum disorders, it adheres or invades into the uterine wall abnormally. It kind of gets stuck inside the uterine wall. And it can be very difficult then to remove the placenta, especially to remove it without a lot of bleeding. So this is a diagnosis that's generally made on ultrasound or in high-income settings, sometimes on MRI. Sometimes it's only confirmed when there's a cesarean delivery, and the obstetrician or whoever's delivering the baby goes to pull out the placenta and find that it's really stuck or that it's bleeding a lot when they try to remove it from the uterus. Generally speaking, this is treated with preoperative planning for cesarean delivery. So a lot of times these people need a scheduled cesarean to avoid having bleeding problems at delivery. Once in a while, it requires hysterectomy if the invasion is very deep. Placenta previa is another disorder that can occur where the placenta doesn't form in the top of the uterus or the side of the uterus as we would expect, but it actually covers part of the cervix. So sometimes it's just a very low-lying placenta right next to the cervix, but sometimes it entirely covers the cervix or partly covers the cervix. Usually this is identified on ultrasound as well, where the placenta location can be seen well, and unfortunately can be difficult to treat. Sometimes it requires bed rest, close monitoring, might require cesarean delivery because there's a high chance of serious bleeding around the time of delivery. So similar to accreta in some ways, the real problem is generally blood flow, but also unlike accreta, there's no invasion into the uterine wall with placenta previa. There's also a disorder called placental abruption, where the placenta abnormally separates from the uterus. So in both of these cases, you can see that the placenta separates from the wall. So it's come off of the wall and formed a pocket of blood behind it. And that could lead to either internal bleeding or external bleeding. And this can be a very serious problem. The amount of bleeding can be massive. You remember I showed you those pictures where the circulation between the fetus and the maternal circulation has those spiral arteries, which really delve into a blood-filled space. That blood flow is essentially limitless. It can be all of the maternal blood until those arteries or those vessels clamp down. So if there's premature separation from the uterine wall, it can both endanger the fetus and the mother's life. The fetus, because then that blood flow exchange is not happening normally, not reaching the fetus, and the maternal side, because so much blood is exiting the maternal circulation and forming this pocket. So this is often diagnosed by clinical symptoms: abdominal pain, bleeding, hypotension in pregnancy. Can also be seen sometimes on ultrasound or fetal monitoring. It might require immediate delivery, monitoring for fetal distress, or blood transfusions, so depending on the severity of the condition. So let's move on to talk about things that are a little more aligned with non-emergent conditions and more kind of a chronic condition. So those are the three most common placental spectrum disorders, but there's also a disorder that has a really wide range of presentations called placental insufficiency. And a lot of the research that we do focuses less on those sort of blood flow or location of the placenta disorders and more on placental insufficiency. So when we talk about insufficiency, what we're talking about is the adequacy of the placental supply of nutrients and oxygen to the fetus. So really talking more about the delivery side to the fetus, although there's also implications for the removal of waste. So what causes the placenta to be insufficient to deliver oxygen or nutrients to the baby? So here on the left, you can see a normal size placenta relative to the baby. An insufficient placenta is generally a little bit smaller in size relative to the size of the fetus or relative to the size of the pregnancy that we would expect at that time. So often this is caused by maternal health issues. Preeclampsia is associated with placental insufficiency, undernutrition in pregnancy or before pregnancy, placental abnormalities in the way those blood vessels form, or the type of surface exchange that they can provide. Infections can cause this, lifestyle factors, including smoking and other substance use in pregnancy. And the outcome is varied, but often the same. So often it results in intrauterine growth restriction. That's what IUGR means here. Also can lead to premature birth, fetal distress, and adverse neurodevelopment or neurodevelopmental risks. This can also be made by ultrasound, by seeing the size and the predicted weight of the placenta using ultrasound. Doppler studies, where the flow in those spiral arteries can be looked at using an ultrasound with Doppler flow. Fetal monitoring can also give this sense, and sometimes maternal blood tests. So usually the treatment for this is monitoring and managing maternal health, so optimizing maternal health if diabetes or nutrition are not well managed, to optimize those in pregnancy, to really manage preeclampsia, the blood pressure, sometimes to deliver the baby early or planning the delivery in a very careful way, and some medical interventions. So often this can be prevented, but not always. There's a lot of disorders that are caused in various ways, both in the maternal health and infections that can occur that may not be preventable. But sometimes prevention is possible, including prenatal care, improving prenatal care and maternal health conditions, lifestyle interventions like stopping smoking and substance use, and better management of underlying medical disorders. So this brings us to our discussion of the developmental origins of health and disease, which kind of goes back to placental insufficiency and all these potential problems that can develop during pregnancy and how they might lead to later health outcomes in children. So this concept, developmental origins of health and disease, is on the rise. People have been talking about it for a couple of decades, but it's only really come into focus as a really important way to think about research around child health conditions. So the concept is that environmental exposures or maternal environmental exposures during critical developmental periods really influence long-term health. So all the way along the spectrum from being a baby to being an elderly person, some of these early experiences can actually program the fetus in utero or early childhood and have long-term health consequences and outcomes. So early experiences can affect the risk of metabolic syndromes. There's been a lot of research showing that placental changes or in utero exposures can actually program metabolic syndromes like obesity, hypertension, sometimes risk of diabetes, and allergic diseases. They've shown a relationship between certain findings in placenta and developing allergies in childhood. Mental health disorders as well. There's a relationship with schizophrenia and autism and some conditions, and more conditions as well, which are still being researched. So the potential factors that could be associated with some of these later life developments include nutrition and stress, as we've discussed, environmental exposures, including toxins during critical developmental periods, and what we call epigenetic changes. So the environment that the fetus or the child is experiencing can alter gene expression, actually. That's the epigenetic part, and influence disease risk. So epigenetic changes are an important area of research that's just developing when it comes to the developmental origins of health and disease. There's a whole field of this that's devoted specifically to the placenta and how the placenta as an environment, a developmental environment, can influence long-term health. So there's actually a Journal of Developmental Origins of Health and Disease. For those of you that are particularly interested in this area, you might find some good reading there. And the placenta features prominently in this journal. There's some research on how the variations in the placenta structure, the placenta function, contribute through alterations in the nutrient transport and also in hormone production. And any of those functions I mentioned could really contribute, but these are two hot topics of research right now. And how those influence the fetal growth, the metabolism in the fetus, and the organ development, which are obviously key components of developing a human being. So the outcomes that are of greatest interest right now in the research field are the risk of obesity, fatty liver, hypertension, and type 2 diabetes. So those metabolic complications that I mentioned, which can have their onset earlier in life than we might have observed previously. So there's a lot of research happening relating the placenta and the placenta disorders to adolescence and to even early childhood when it comes to asthma and some other allergic disorders. Also, cardiovascular disease. There's been some really interesting research showing risk of coronary artery disease and placental disorders. So coronary artery disease that might only develop in the age range of the 40s or the 50s or the 60s, and how that might relate to what happened in the placenta during development. And also neurodevelopmental disorders, which is actually an area that we're working on researching, and our cohort that we're working together with Joseph Ngonzi and other researchers at Mbarara University of Science and Technology in Uganda. We're very interested in the area of neurodevelopmental disorders. So I want to talk a little bit about the developmental origins of health and disease with respect to inflammation as well, and also infections that occur in pregnancy. So this is an interesting article that was published 4 years ago for anyone who's interested in this area by some colleagues of mine who are based at Northwestern University and Pennsylvania State University here in the US. So they're talking in this article about how the placenta has really become a new area of focus within the developmental origins of health and disease research. This is a schematic kind of showing how some of these processes might occur and how many of the processes I just mentioned, those outcomes in children could be related to inflammation at the placenta, in addition to the other things that are possible contributors like blood vessel formation. So maternal inflammation and comorbidities, maternal and fetal genotype, and obesity, maternal obesity and infections can all contribute to inflammation at the placental level. So this is both cellular and humoral inflammation that can be created. So you see a T regulatory cell here as an example, humoral immunity represented here by the antibodies. And then there's cellular factors as well with production of cytokines and chemokines locally in the area. And all of these can be recruited by those Hofbauer macrophages produced by the Hoffbauer macrophages or other immune interactions at the maternal fetal interface that can really affect the placenta. So some of it is related to maternal inflammation. And let's say there's an infection in pregnancy or maternal genotype or inflammation around obesity that creates some of these inflammatory factors. They get recruited to the placenta or they act on the placenta white blood cells that are there, and they can really affect the way that the placenta grows and adapts, because the placenta is responding to signals from both the fetus and to the maternal circulation. And so during those critical periods, it's not totally clear exactly what the mechanisms are, but it's hypothesized that these mechanisms, inflammation that's maternal from maternal diseases or maternal infection, can really influence the development of the placenta, especially inflammation itself, with the recruitment of white blood cells and cytokines, change the development of these spiral arteries that are seen here, and eventually lead to end organ change. And there's a picture here of the brain and the lungs, because those are two of the most affected organs that actually share a developmental origin with the placenta. And the formation of those organs is basically happening at the same time and using some of the same cellular signals as the placenta. So these factors that we may not even really think about can actually result in organ changes with lifelong effects. So how would this really work, and what can we really think about as a consequence? So maternal fetal inflammation can be either acute or chronic. So we sometimes see this if we look at the placenta. We can look at the placenta and do histology. So we can take a placental section, take a piece of it, of the membranes, of the umbilical cord, or the placenta disc itself. We embed it in formalin, and then we can stain it using hematoxylin and eosin H&E staining, put a slide under microscope, and see both acute and chronic inflammation. Acute inflammation looks different from chronic inflammation, a different type of white blood cells, a different structure to the disc. But that's often labeled chorioamnionitis, acute chorioamnionitis, which we can see histologically. That's a type of acute inflammation that usually occurs over days, maybe weeks. There's also a chronic form, which has more to do with smaller white blood cells that have infiltrated the space over a longer period of time. Sometimes that's similar to kind of a rejection-like phenomenon that you might see in an organ transplant recipient. Remember, I told you that the fetus is kind of a not self. So it's part paternal DNA, it's part maternal DNA, and those combine. So the maternal side of it is seeing some tissue that is not actually considered self, and can lead to kind of a chronic rejection phenomenon that may also be contributed to by infection or maternal inflammation from maternal conditions like diabetes, HIV, obesity, other things. So both acute and chronic inflammation that we can see at the histologic level have been associated with some disorders, including asthma, cerebral palsy, neurodevelopmental disorders, which I'll get a little more into, and autism spectrum disorder. But the long-term outcomes of these conditions in pregnancy, acute and chronic inflammation, and these diseases are not really well studied, nor the mechanisms, the specific mechanisms at a cellular level, a molecular level, or an interaction level between maternal and fetus. They're really not well known. So studies of placental pathology, particularly of those inflammatory lesions, could really contribute greatly to this field. And that's an area of research that we're working on. Also, these colleagues who wrote the paper that I mentioned, and many other people, really trying to understand what the mechanisms are and how we then might be able to interrupt those mechanisms and improve the outcomes. There's also a really interesting area of research in the developmental origins of health and disease area that's referred to as the placenta-brain axis. So I mentioned briefly that there's some commonalities in how the placenta responses promote survival in utero, and also the way that the brain and placenta develop together. So the way that the placenta responds can influence brain development, and then there's also some shared origins in the way the blood vessels form, with vascular endothelial growth factor affecting both placenta formation and brain formation, and many other neuroendocrine factors. So there's a lot of neurotransmitters that are produced by the placenta: serotonin, dopamine, norepinephrine, and epinephrine. They circulate and can influence fetal brain development, and in turn are influenced by maternal stressors and utero stressors. So some neurobehavioral disorders may trace their origins back to placental disturbances. There's a review on this for those who are interested in reading about the placenta-brain axis that is titled that. That's really very interesting, and it really describes why there is this shared origin, what the neurotransmitters are that are involved, and how those might ultimately influence the outcomes in children who are exposed to inflammation or changes in neurotransmitter levels in utero. All right, let's move on to talk a little bit about maternal infections in pregnancy and some child health outcomes. So I'm going to review some of the common infections that we talk about that are really important for child development, fetal development, and that can also pass across the placenta and their potential implications. So we're interested in our research and really understanding what the impact is of maternal infections in pregnancy. So some infections really don't impact the fetus or development, or don't have a lasting impact, but there are some infections that really have very important have really important implications and potential outcome implications for the child. So some of the infections can directly impact the placenta. They go to the placenta, they can infect the placenta, they can alter placenta nutrient and gas exchange. Some actually just cause maternal inflammation and can impact the placenta through the mechanisms that I was just referring to. The ones that can cross the placenta are often called by this acronym TORCH, which refers to pathogens that can really cross the placenta and are associated with congenital disease in the newborn. So T is Toxoplasma gondii, O is other, which is actually a lot of different things. So that's why sometimes this acronym isn't as helpful. R is for rubella virus. C is for cytomegalovirus, and H is for herpes simplex virus. So helpful to remember that these are infections that are important, but it really doesn't cover everything. So we'll talk about some of the others. Some of the common infections in pregnancy that are present in sub-Saharan Africa that you might encounter in your daily practice include malaria, HIV, tuberculosis, syphilis, and cytomegalovirus. So up on the first bullet, I've put their potential impacts on maternal health, and in the lower bullet, their potential impacts on child health. So as we all know, malaria can increase the risk of miscarriage, preterm birth, low birth weight, and can cause anemia in the mother, which has its own onward potential effects. And there's also a higher risk of neonatal mortality and cognitive impairment in children who are exposed to maternal malaria, which is why we work so hard to prevent malaria and to treat malaria in pregnancy. I'll talk a little bit more about malaria in a minute and show you some of the interactions that happen at the maternal-fetal interface that are really important. HIV obviously can have a risk of maternal to child transmission, both while in utero, but also in the perinatal period, so during breastfeeding and the months that follow birth. Preterm birth can also be associated with HIV and low birth weight. In children, there's a higher risk of HIV infection if they're born to a woman with HIV, and some developmental delays, which is one of the things that we're trying to study in Uganda. If the pregnant woman has tuberculosis, there's an increased risk of maternal mortality, preterm birth, and low birth weight as well. And then also congenital tuberculosis can occur. It's pretty rare, but there's also some fetal programming that probably occurs around the immune response to tuberculosis that has been associated with an increased risk of infections in the offspring. Syphilis is also on the rise. The epidemiology of syphilis is changing, and we're seeing both in the US and in many countries around the world a rise in syphilis in pregnancy and syphilis prevalence overall. Syphilis includes a higher risk of stillbirth, unfortunately. That's one of the things that we've seen in Uganda as a manifestation of the increase in syphilis prevalence. There's also a risk of congenital syphilis, which can include neurological, skeletal, and growth abnormalities. And for the children themselves, there can be long-term health issues if it's not recognized early and treated. Cytomegalovirus is another infection that'll go into a little more detail, but there's risk of congenital cytomegalovirus infection, and more attention is being paid to cytomegalovirus as a virus that goes along with other things. So we'll talk a little more about this, but it can be both a chronic infection that gets reactivated, an acute infection, and sometimes it gets reactivating in the setting of maternal stress. If untreated, it can lead to long-term disabilities and some developmental delays as well. In terms of the effects of maternal infections on child health, there is perinatal transmission for some of these infections. Some transmission can occur in utero and affect the fetus directly if it crosses that placental barrier. And sometimes transmission can also occur after pregnancy through breastfeeding, through saliva, through blood transfer. The placenta immune response can also have its own effect. So even if the infection itself doesn't reach the fetus or the neonate, this immune response that we talked about and the inflammation that can occur at the level of the maternal fetal interface can also affect the child. Intrauterine growth restriction can be associated with some of these maternal infections, as can some changes in the placenta vasculature. And then there's effects on fetal development in terms of disruptions to those important functions that we just discussed. So disruption of nutrient transport, the inflammation, and interference with the normal fetal development. So there's multiple levels on which these infections are actually important, not just on the direct infection of the fetus. There's a great review on this if anyone is interested in reading more by Carolyn Coyne and Christina Megli about infections at the maternal fetal interface and the pathogenesis and defense. So this is fairly recent. It's in Nature Reviews Microbiology. It's a really great look at the mechanisms of defense and the mechanisms of infection and how this kind of collateral damage around inflammation can occur and really affect fetal and maternal outcomes. So I'll show you a few images taken from this article, which I think is a really great article. So I just want to review that there's these defenses that exist that ideally would protect the fetus, but they're not perfect defenses. So physical defenses, we mentioned that there's these tight junctions and lack of cell-cell junctions in other places that really allow the syncytial trophoblast and a dense actin network to prevent the entrance of various pathogens. There's a constitutive release of effectors, including the cytokines and antimicrobial peptides, and this is all at the level of the placental villus. So that's what's shown here. That kind of looks like a tree with all the network of blood vessels and capillaries where exchange occurs. And there's innate immune defenses. So here's 3 potential pathogens that could affect the fetus. And you can see that cytokines and chemokines are released at this level to try and kill those pathogens. So what are the mechanisms when things go wrong? So I showed you what ideally would go right. We have physical defenses, we have chemical defenses, but the mechanisms by which pathogens actually cross are a little unclear. How do they get past those tight junctions? How are they not killed by the cytokines and the chemokines? Why is this inflammatory response not always effective and actually sometimes potentially harmful to the fetus? So that's a really important area of research, and some of the mechanisms are known, but a lot really aren't known. So some may use pathways to bypass the placental barrier that are similar between pathogens. So they might actually infect the extravillous trophoblast, which is what's shown here. They might actually affect the maternally derived decidua. So they might go through maternal immune populations. They might actually get into the maternal side here, and then through the shared blood flow, enter through this villus, sort of using the blood as a way to access the fetus. There might also be direct infection across the chorionic villi through the syncytium, which is shown here as direct infection of the syncytial layer. And there also might be inflammation-mediated damage. I mentioned we see histologically that inflammation occurs in these tissues. Well, some of that inflammation actually includes tissue damage and destruction. That disrupts these normal tight junctions, these barriers that normally would be present. And through those disruptions, just like a break in the skin, a pathogen could enter. So these are some of the postulated ways how these pathogens might actually get across and cause infection in the fetus. But this is a really critical area of research, and it's very difficult, mostly because we can't really observe this in situ. So we can't biopsy the placenta while it's in place. We can't get such a microscopic look while these functions are actually happening. So that's a really important area of research, is how can we actually get better visualization? What can we do to really understand better? So one possibility are animal models, but right now we actually don't have a great animal model for pregnancy. So some animal models use the guinea pig, actually, which is a small furry animal that I don't think is native to Kenya. Some models use sheep and some models use mice, but none of those are actually great models for human pregnancy. So that's a huge challenge. And this mechanism, I think, is a really important area of research for those of you that are interested. So I want to talk about two specific infections in pregnancy briefly to tell you a little bit about what seems to be happening at the maternal-fetal interface. Firstly, malaria, and then we'll talk about cytomegalovirus. This is a great review on malaria in pregnancy. It's basically talking about placental infection and the abnormal things that can happen. So for those of you interested in reading more about placental malaria and malaria in pregnancy, this is Frontiers in Microbiology from 2021. And there's some really nice diagrams, which I'll show you. So this is their version of the image of what happens in placental malaria. So here in this diagram, the parasite is shown in yellow. You can see the parasite here adhering to red blood cells that it infected in the maternal circulation. What's interesting is that these parasites actually do access the placenta through the maternal circulation. They enter this intervillous space where there's that shared area between maternal and fetal circulation, and they replicate there. It's actually a really nice home for them, which somehow manages to evade immune response. And that's a really interesting area of research as well. How does it evade the immune response? So one of the leading theories is that it undergoes antigenic variation, so that the parasites actually change the antigens on the surface of the parasite that mean today it looks like one thing and tomorrow it looks like something else. So it basically like puts on a different outfit every day, and the maternal immune system is no longer able to recognize it. So while the maternal immune system is trying to catch up, produce new antibodies and new effectors to go out and kill the parasite actually changes again. So that's a concept of immune escape that allows a parasite to replicate without being killed. Sometimes eventually the immune system catches up. Sometimes there's other therapies like drugs to treat malaria that kill the parasite, but sometimes this development goes on unchecked and the infection can proliferate. That's one of the reasons why malaria sequesters in the placenta, is because of this concept of immune evasion. So the maternal anemia and parasitemia really then kind of prevent nutrient transport across the placenta, lead to oftentimes a small placenta with growth restriction as a result. So that really can negatively impact the fetus and lead to low birth weight, slower and delayed neurodevelopment, and other adverse outcomes. The physiology and pathology of malaria in pregnancy really starts in the first trimester. That might be the highest risk time. As I showed you earlier, that's when the blood vessels are really invading, the fetal side of the blood vessels are invading into the maternal side to establish that blood flow. And that can be a high risk time in terms of placental growth and development. Can lead to permanent placental damage with broken syncytial trophoblast layers, thickening of the basement membrane, which then interferes with nutrient transport, increased syncytial knotting. So those little areas that we were witnessing where the blood flow occurs, they can develop these knots where they're less functional, increased areas of necrosis and fibrosis, and dysregulated apoptosis of the trophoblast, which are supposed to have programmed cell death and may not undergo the cell death the way they're supposed to. So all of this can add up to placental insufficiency, intrauterine growth restriction, low birth weight, and is also associated with preeclampsia. So this is another version of that image showing that the pathology is really associated with the activation of the local immune response. So this is the maternal side, again, with these spiral arteries where there's increased intrauterine artery resistance. So the blood flow, it just has a harder time getting across. There's essentially hypertension in this area. Thickening of the basement membrane, which prevents the transfer of nutrients between the fetus up here and the maternal side down here. apoptosis that's dysregulated, the fibrinoid necrosis, broken syncytial trophoblast, which also is a risk for other infections to enter, reduced villus surface area for that exchange that's so important, and then all these inflammatory cytokines, so TNF alpha, interferon gamma, increased complement. So it's really can be quite damaging, especially placental malaria. So these are some of the effects that can happen, especially if placenta malaria goes untreated. So now let's talk a little bit about cytomegalovirus. And I think cytomegalovirus in pregnancy is becoming an area of focus in pregnancy-related research because it's been understudied in the past and it's so common. So it's a virus that infects over 50% of adults by age 40, in some settings up to 95%. The seroprevalence is high in sub-Saharan Africa. It's the most common cause of congenital infections worldwide. It's the most common congenital infection. 1 in 200 infants in high-income settings are born with congenital cytomegalovirus of some degree of severity, and about 3 times that in low and middle-income countries. 1 in 4 of those children have lifelong consequences. So it could be hearing loss, it could be other things I'll talk about in a moment. Transmission occurs by direct or indirect person-to-person contact. It actually can be spread through saliva if there's a high viral load, through semen, milk, tears, cervical and vaginal secretions, and blood products. And there's prolonged viral shedding with an initial infection, so that means it can be contagious for often weeks during early infection, sometimes only days. What happens with congenital cytomegalovirus? So it is the most common congenital infection. The most common manifestation of that is sensory neural hearing loss. So up to 10% of cases will get unilateral or bilateral sensory neural hearing loss. The risk of fetal transmission and maternal infection is highly variable. So it's 30 to 35% generally speaking with primary infection, but only 1 to 3% during non-primary infection. So during primary infection, cytomegalovirus actually infects the nervous system, the nerves, and it lies latent generally throughout a lifetime. So most people's bodies never rid themselves of cytomegalovirus, but it doesn't cause a problem because it's kept in check by the immune system. For some people, for various reasons, it can reactivate. So that's what I mean by non-primary infection. There's a reactivation that can occur with HIV infection, with serious trauma even, or critical illness, and the virus can come back out into the bloodstream because the immune system, in this case, the maternal immune system, can no longer keep it in check because of these other stressful events. Reinfection is also possible with a separate strain or a quasi-strain of the same virus. That's less common as well. So during reactivation, the viral loads are lower and the risk of congenital infection is also lower, but it's still there. So if congenital infection occurs, it can be associated with neurodevelopmental delay, also microcephaly, so a small brain size, petechiae, so skin rash on the surface, or change in skin color like jaundice. Usually the gold standard for diagnosis is urine or saliva samples from the baby. It's hard to diagnose. It requires PCR testing, and there is no really great test, unfortunately. And surveillance is really not very common, both for cytomegalovirus and for the effects of cytomegalovirus, including hearing outcomes. Some of the features you can look for if you are seeing a neonate is looking for small for gestational age baby, which, as we mentioned, intrauterine growth restriction can occur in many different diagnoses, so this is not specific. Microcephaly, so a small brain or a small head size, or kind of an abnormally shaped small head. Petechiae, purpura, or what's called a blueberry muffin rash, so dark spots that can happen on the skin. Jaundice and hepatomegaly, so a large spleen or a large liver. Neurological signs without any other explanation, so hypotonia in the neonate, poor sucking reflex, seizures, and then sensory neural hearing loss, unilateral or bilateral. That's often really hard to diagnose in a neonate. Sometimes it only presents later in infancy or even in toddlers. Chorioretinitis can also be a sign, retinal hemorrhage, but those aren't usually seen on exam, sometimes strabismus or cataracts. As I mentioned, the diagnosis gold standard is PCR. Amniotic fluid is really the gold standard, but no one really does amniotic fluid diagnosis, except in very rare circumstances, even in high-income settings. So generally, it's confirmed using urine or saliva within the first 3 weeks of life, and usually 2 confirmatory tests are needed just to be certain. Hearing-targeted programs are also very helpful in identifying children who might have congenital cytomegalovirus. There is treatment for children. Unfortunately, there's no treatment in pregnancy because the treatment is fairly toxic in pregnancy. So it's important to try to identify it and recognize it, but unfortunately, 95+% of congenital cytomegalovirus is probably undiagnosed in the absence of routine screening programs to do saliva or urine PCR testing. So this represents a huge area of missed opportunity and a really great area for research. Cytomegalovirus and HIV also have an interaction. Cytomegalovirus viremia, the presence of the virus in the bloodstream, is more common in women with HIV than HIV uninfected pregnant women. And the risk of transmission of cytomegalovirus to the child increases by 20-fold in children who are even HIV exposed but not infected. And interestingly, it's not associated with maternal CD4 count. It's not associated with antiretroviral therapy duration. So the mechanism underlying this is still a bit unclear. And both HIV and CMV together may actually trigger placental inflammation with all the follow-on effects that I mentioned. However, those placental effects haven't really been robustly measured, and this is one of the areas of our research in Uganda. So I'll just show you very briefly some of the effects. I did a PubMed search, I think this was 2 or 3 months ago, for CMV, HIV, and the placenta, and I only got 9 articles. So there's not a lot that's been researched on the co-infection and its potential effects, despite how prevalent these viruses are. And the impairment is really important in the pathogenesis of cytomegalovirus. CMV replicates in the cytotrophoblasts, interferes with differentiation and invasion, so it can actually cause abnormal placentation. It inhibits the development of those placental villi, which are so crucial for exchange, can lead to edema and fibrosis, impaired transport, and those ultimately lead to intrauterine growth restriction. It can also occur due to impairment of placental function. Intrauterine growth restriction can also occur in that setting. So even if cytomegalovirus infection doesn't reach the fetus, intrauterine growth restriction can occur, and that can have its own follow-on effects, as we mentioned. It's a very similar mechanism to the other placental insufficiency-related disorders we discussed, and the timing of infection is associated with its severity. This is a map to show you where we have data and where we don't have data. So you'll see that in sub-Saharan Africa, most of this is grayed out because we don't have a lot of data, but then there's a high prevalence in many parts of the world where we do have data that are low and middle income countries, and still a high prevalence in high income countries. So these areas here are like 50, 60%, these are greater than 90%. So it's very common worldwide. I think we all should probably be looking into the effects of CMV and congenital CMV more. In low resource settings, the prevalence is really much higher, but there's really a limited infrastructure to identify placental infection, which, as we discussed, might be associated with congenital CMV. So I think this is an area to build capacity for the future for the detection and management of CMV. In the Gambia, there was a great article that came out. It's a little older now, 2008, but they found that at birth, 4% of newborns in their setting had congenital CMV and 85% at 1 year. So I show this to you just to demonstrate how common it is and how important it is that we build programs around this. The placental effects of CMV, I mentioned to some degree. This is an article for those of you who are interested in delving deeper of 37 newborns diagnosed with congenital CMV, showing that essentially none of them had a normal placenta. So only 1 placenta, and that was in an asymptomatic congenital CMV case, was normal. But there was chorioamnionitis, as I mentioned, inflammation of the placenta, villitis, which is another type of inflammation, and they really saw a lot of problems in the placentas where congenital CMV was present. Okay, so I'm just going to tell briefly about the current areas of focus for research and then what you can tell your patients, and then we'll move on to our question and answer session. So there's a lot of research happening around the placenta. I want to highlight the Human Placenta Project, the HPP, that the NICHD, the National Institute of Child Health and Human Development here in the US, carried out. So I think this started in 2015. And their objectives were really to improve our methods of researching the placenta. As I mentioned, a lot isn't known about the placenta, especially the mechanisms of these adverse outcomes. Apply technologies to understand and monitor in real time what's happening. How can we know before birth what we can do? How can we diagnose disorders in pregnancy? And especially to develop and evaluate non-invasive markers for prediction of adverse outcomes and understand this developmental origins of health and disease concept. What is a placenta contributing to the long term, and how can we intervene? So you can find this on the web, more about the HPP. This is their schematic of what they were looking at. Some of the important diseases they were interested in were preeclampsia, gestational diabetes, preterm growth and growth restriction, and stillbirth. And there's quite a few articles that were produced, but I think one of the takeaways from the HPP is that there's still so much more work to do. I think they were hopeful that they would get a really comprehensive look and a series of diagnostics that would come out of this project. And there's still a lot more work to be done. So look at it and find areas where your work could fit in. So this is kind of their approach. They really wanted to identify components in maternal blood, including proteins, lipids, and RNA that could be used as diagnostic. There have been some articles that have shown success in those fields, but there's still a huge lack of tools to diagnose in real time in pregnancy and intervene on these disorders. Specific to infections, we actually edited a supplement to the Journal of Infectious Diseases in 2021, myself and Rebecca Zash, looking at the research agenda for infection. So if you're interested in what our thoughts were and some research, especially from sub-Saharan Africa on the placenta and on the impact of maternal infections on the placenta, you can check out some of the articles. But one of the things that we really felt is that there's a really incomplete understanding of the effects of maternal infections, including those high prevalence disorders in sub-Saharan Africa: malaria, HIV, hepatitis B, group B strep, other bacterial infection, SARS-CoV-2 or COVID-19, cytomegalovirus, and the torch infections. And we also wanted to know more about how antiretroviral medications affected placental development and function. So we sort of argue in this issue and the editorial that accompanies it that more research needs to be done, especially on mechanisms, and more capacity building to do research in the settings where these disorders are highly prevalent. So the current research foci that I've seen in the literature right now are on mechanisms of transmission. I mentioned to you that a lot of the mechanisms of invasion and inflammatory response really aren't known. Development of better tests. We don't have great tests for cytomegalovirus. Even malaria in pregnancy is hard to diagnose sometimes. Zika and group B strep, we don't know even how to diagnose those in the placenta right now. Using advanced imaging like better ultrasound or like higher resolution ultrasound, MRI, other things that we could use to detect these infections early, and not just for high income settings, but across the world. How do these pathogens evade the immune system? What are those mechanisms? I talked about the one for malaria, which is this antigenic switching that can make it invisible to the immune system. But what are those other mechanisms, and how can that give us insights? What antiviral and antibacterial drugs can we use? We don't have treatments for all of these things. What are the genetic and epigenetic influences that are happening? How can those influence lifelong health? What's the influence of the maternal microbiome on infection susceptibility? What factors affect placental barrier integrity? All those different layers, the physical ones, the inflammatory ones that I mentioned. And what are the long-term outcomes? Are socioeconomic factors involved? What are the social determinants of health? We need a better animal model, truthfully. We have a paucity of good animal models to study this. And ideally, we'd also be leveraging big data multi-omics approaches to understand these molecular mechanisms and complex interactions. It's probably not just one thing that contributes to any of these disorders. And clearly, we need to develop more vaccines to prevent these vaccine preventable diseases. So Zika, cytomegalovirus, group B strep, need to work harder to prevent rather than just diagnose and treat. So I think there's a lot of future directions. It's going to be collaborative efforts for across disciplines. So obstetricians, gynecologists, infectious disease, pharmacists, midwives, nursing colleagues, everybody needs to participate. We should ideally be sharing data better and sooner so that we're not all reinventing the wheel in our own environments. And ideally, we'd enroll more women in clinical trials. I think that's one of the challenges of research, is that we've traditionally not enrolled pregnant women in clinical trials, and we need to find ways to do that that's safe and includes basically participatory research. So what should you tell your patients? I'll leave you with this before we go on to our question and answer. Sometimes it's hard to know. There's been an overwhelming amount of information. How should I counsel my patient? So the CDC in the US developed some things, tips for pregnancy, for preventing infections before and during pregnancy, some of which are relevant to other settings. I don't know if Africa CDC has their own version, but these are 10 tips that the CDC suggests that I think are largely relevant. So protect yourself from mosquito bites. This is helpful for malaria, for Zika, for dengue. Wash your hands with soap and water. It sounds very simple, but it's very important. Reduce contact with saliva and urine from babies and young children, in part because of the cytomegalovirus that I mentioned to you, which can be have a high viral load and can be transmitted through saliva. Avoid unpasteurized raw milk and the foods made from it. Don't change dirty cat litter, which is, a problem in some settings and not others, but that can be a risk factor for toxoplasmosis. Staying away from rodents and their droppings. Get tested for diseases that could be transmitted, including HIV, hepatitis B, syphilis. Get vaccinated. I put this in red below because to me it's so important. And avoid people who have an infection that could be transmissible, and ask your doctor about group B strep. So those tips are available at the CDC. So in summary, I just want to say that the placenta plays a critical role. I hope I've proved that to you today and demonstrated how important it is in both maternal and child health. The developmental origins of health and disease model is a really useful construct to help us think about how the placenta could play a role to key lifelong health determinants. Maternal infections really do impact placental function. They have consequences for child health that are both direct and indirect. And we're really just beginning to understand the complexities of the placenta and its function and the impact of placental inflammation and infections. And we need further research. So any of you who are interested in research in this area, I hope that you will be inspired to study the placenta, which is so important. There's a lot of work that needs to be done, and it has to be collaborative, both on biology, mechanisms, effective strategies, health delivery at every level of the system. So I can send you my references. This is my email address. I would love to hear from you, lbbell@mgh.harvard.edu. I know Jessica Haber, who is a very admired colleague and mentor of mine, also said the same. So we would be delighted to work with any of you or to hear from you more. And I will open the floor as per the moderator's discretion to questions and discussion. So thank you so much for your attention. I'm really grateful for your time.
Thank you so much, Dr. Lisa, for that presentation. I hope we all enjoyed it, and I hope it sparked our interest in the placenta, that we even start taking a look at it, taking it for histology, and I hope it triggers some of us to go into placental research. We can tell you're very passionate. Thank you.
Thank you.
We can go into the Q&A. So for those who have had their hands up, kindly put in your questions in the chat box, and then we will answer them as we go along. So first question, what would be the effect of placental injury? What would be the effect of placental injury, maybe through an accident? I think if I've gotten that right.
Yeah, thank you for that question. I think you're referring probably to like a physical trauma. And if that's the case, the Potential effects would be on damage to the placenta, sort of physical damage to that area of exchange of blood flow. So there's potential to have bleeding, there's potential for placental rupture or dysfunction that could have effects both for the pregnant person and also for the developing fetus, especially if there's a significant amount of bleeding that can interfere with the maternal fetal exchange and can also lead to maternal blood loss. So there are cases that I'm aware of that placental injury has led to early delivery. Dr. Agutu, you might have more insight to add to this. Do you want to add anything?
Yes, placental injury during an accident, which can cause sharing of the placenta and causing a placenta abruptio, that would easily lead to either revealed or concealed bleeding that may need urgent preterm delivery. So yes, it can affect it through trauma. Dr. Lisa, I wanted to ask you a little bit about the placenta, and when you talk about when you have injury to the placenta, where we look at vascular changes and also looking at histological changes. So in the case of infection and inflammation, and it happens in the early pregnancy, would that interfere with the villus maturation in terms of forming secondary and tertiary villi in the villus tree?
Yes, so events early in pregnancy can interfere with the normal formation of the villus tree. And one of the ways that we can see that is by looking at the sort of the villus blood density, the villus blood vessel density, and the branching patterns at the time of delivery. So we've done some research using H&E stain slides looking at that. But we've also done stereology where we've taken the paraffin embedded sections of placenta. So they're actually just those tissue sections and cut them at different angles and looked in depth at the way the blood vessels are formed. So the branching angles for those blood vessels and also the number of those blood vessels per square area. So that's some of the way that we can actually see that physically in the placenta. But yes, that's definitely one of the types of interference that can occur through inflammation or through abnormal sort of circulation of the factors like the vascular endothelial growth factor and the other factors that influence the blood vessel development.
Okay. Yeah, we have another question. Is there an increased risk of malnutrition as well, that is undernutrition with stunting and underweight? I'm assuming as a result of placental injury.
Yes, there is. Different types of placental injury would be higher or lower risk for that. But as we talked about with placental insufficiency, that can be associated with intrauterine growth restriction, and intrauterine growth restriction can be associated with stunting or underweight in childhood. Much of that is recoverable. Children can gain weight and grow up to be normal weights, but that is a potential association.
Okay. And you had talked about further research in terms of microbiome. And there's a question here that does maternal intestinal flora have any role in placental insufficiency? And if so, would probiotics be of any use?
Yeah, another really interesting question. So I don't know of any research that has looked specifically into the maternal microbiome and like maternal intestinal flora and placental insufficiency. So I think that's a really interesting question. There are changes in the maternal microbiome that are caused by maternal disorders. So it's not crazy to think that that might have an impact. But I'm not aware of any specific research in that area, and I think it's a very interesting question.
Okay. Yeah, very interesting. We have an interesting question about, can the level of HCG predict possibility of placental insufficiency? Because I know when we look at HCG, we usually look at it in terms of determining whether a pregnancy is likely to be viable or not, in terms of the rate at which the HCG level rises, especially in early pregnancy, when you're trying to determine if it's viable or not, or when we're doing screening for chromosomal abnormalities like Down syndrome, where we would use HCG.
Yeah, that's also a great question. I don't know the answer to that. I would be surprised if HCG alone would predict placental insufficiency, since there's so much research that has been done on it. But it may be one of several markers that, since it's produced by the placenta, and a placenta has to produce enough to maintain pregnancy and be detectable, there may be some correlation, but I'm not aware of research on that either.
All right, these are really good questions for research. How do you differentiate cerebral palsy from autism spectrum in terms of clinical presentation?
That's an important question. I'm definitely not an expert in that area, but I will say that it probably requires expert diagnosis. So a child would probably have to be seen by a developmental expert and undergo some developmental testing to know that. There may be some differences in physical manifestations, but in terms of the neurologic, neurodevelopmental manifestations, I think that would require an expert diagnosis to evaluate.
That is true. I think you had touched on this about the role of the placenta in TB transmission and diagnosis. Had you discussed?
Yes. Just to discuss that, what is the role of the placenta in TB transmission and diagnosis? Yeah, so TB can be congenital. It's very, very rare. So TB can cross the placenta and enter into the fetal circulation, and children can be born with tuberculosis, but it's extremely rare. More commonly, TB has negative impacts on the health status of the pregnant person, and that in turn has negative impacts on the fetus. So congenital TB is extremely rare. The diagnosis, I'm not even sure how you would diagnose it in children. I assume that it would be through blood culture or through gene expert, but I have not seen a diagnosis made myself, so I'm not sure. But the placenta, I think more commonly is just an indirect mediator of those effects on the maternal health. So through mechanisms of placental insufficiency and other changes that can negatively impact the fetus.
All right. There's some that I guess we will answer them together. Is chorioamnionitis an indication of immediate delivery of the baby? As one asked. Yes, usually when you do have chorioamnionitis, we have risk of infection also to the baby. So in a case of a patient who had like a preterm rupture of membranes, and we would try conservative management, but once we get chorioamnionitis, then it's important to deliver. I think that one I would cover. Let's see, can malaria in pregnancy cause placenta abruptio?
Yes, I think that there are cases where it can, but I haven't seen that. So I defer to you, Dr. Ogutu.
Yes, well, it doesn't commonly cause placenta abruptio. Most of the time, what we call, when you talked about the parasitemia that happens in the placenta, and more of causing a placental insufficiency and intrauterine growth restriction and a likelihood of fetal death. So that's what is more likely for malaria to cause in pregnancy than abruptio. Let us see, can placental malaria cause eclampsia? So what placental malaria would do is that it would cause a placental insufficiency, as I've just said, leading more towards intrauterine growth restriction and intrauterine fetal death. But if we got a malaria infection early on that interferes with, if you had a malaria infection in the first trimester, and it would interfere with invasion, the syncytial invasion of the spiral arteries, then that could then predispose you to preeclampsia. What do you think? If it was in
Yes,
the first trimester.
there has been an association with development of preeclampsia depending on the time of infection. I agree.
So if it was in the first trimester, then they would have a risk of preeclampsia and therefore be able to have a risk of eclampsia. Let's see, can we share the slides? So we have an effect about what causes placental abnormalities. I think she meant in terms of placenta creta syndrome and spectrum, placenta creta spectrum and abruptio. So when we're talking about placenta abruptio, where we're talking about shearing off of the placenta from the uterine wall, common cause, especially in our setting, is usually related to hypertensive disorders of pregnancy, usually the more severe form in terms of preeclampsia and eclampsia. Could also be due to trauma. Placenta creta spectrum is usually occurring when you have an overinvasion of the wall extending into the myometrium and sometimes going into the bladder. And then you get an adherent placenta, and of which its commonest risk factor would be, for example, if you've had like a previous cesarean section and you have invasion and attachment, for example, onto the cesarean section site. Let's see. Pendo asks, what is the effect of immune-mediated diseases like SLE to the placenta?
Yeah,
Lisa,
also a really good question. So I'm not an expert also in those rheumatologic disorders, but the antibodies that are produced can actually interfere with the blood exchange between the maternal and fetal side. So sometimes you can get blood clots at the maternal fetal interface. And also it can also interfere with placentation. Sometimes the antibodies can interfere with placentation. So there is a role there, and it's really around the inflammation and the way that the antibodies mediate placentation that can be normal or abnormal.
all right. What else have we talked about? Let's see. What are the effects of hepatitis B in pregnancy, and how can this be managed? So you can take us through the effects, and then we can discuss how it can be managed.
Yeah, that's also a great question. So hepatitis B can also be transmitted from mother to child. And so it's really important that people get vaccinated if they're at higher risk or take prevention to prevent the hepatitis from transferring. So congenital infection obviously is not good for the baby, and it can include all of the same symptoms of hepatitis in other people. So jaundice is possible, liver dysfunction is possible. It's not very well studied, but it's really important that we get people tested and get prevention where it's available.
That is very true. The questions are coming in fast. Is it impossible to get a malaria test positive in a below 2-week newborn? Is it impossible? Can you get a malaria positive result on a 2-week newborn?
Yeah, this is a complicated question, and I appreciate your perspective as well, Dr. Gutu. So malaria testing is challenging, as we know, and the trick here is that a lot, depending on the type of testing, the testing in a young newborn may still remain positive because of the maternal response or maternal transfer of antigens. So it can be difficult to diagnose congenital malaria, which does occur. Malaria can be congenital. So it's not impossible to get a malaria test positive, but it can be very challenging to know if it's a true infection or not. Dr. Gutu, what would you add to that?
Yes, that's very true. So most of the time, malaria, of course, for us is very seasonal. So many times we would treat the mother, but it's very difficult to tell for the baby at 2 weeks whether that result is as a result of the mother or as a result of the baby. So usually I think that's at the discretion of the pediatrician in terms of whether to treat, especially in congenital malaria, and how to diagnose it. Let us see. Medical management of severe malaria in the first trimester of pregnancy. What do you use in your setting, Dr. Lisa?
That's a great question. I think we're using artemisinin-based therapies at the moment, but in the past we had used quinine. So I'm not sure what's the first line right now, because I don't usually treat a lot of pregnant women in that phase of pregnancy. What is in your setting?
So yes, we used to use quinine, but we still do use artemisinin-based treatment in the first trimester, especially with severe malaria. And sometimes we combine it with an antibiotic, if I'm not wrong, it's clindamycin. But I will check the current guidelines as we go along. There are others in terms of what's the mode of delivery for placental calcification, that is grade 2 or 3 at term. So placental calcification occurs especially as we get to term as the placenta ages. So just the calcification on its own does not necessitate a cesarean delivery. We'll still have a natural birth as we monitor the baby. But if there are any signs of an abnormal CTG, especially a category 3 CTGs, that one would intervene and have a surgical procedure. But calcification on its own is not a determinant of cesarean delivery. Any agricultural chemicals that have a direct effect on the placenta? Good question.
Yeah, that's a great question. So there are some known toxic chemicals, and there's been research on this. Sometimes they're labeled as, pregnant people should stay away from these chemicals. I don't know the names of them off the top of my head, but there definitely are impacts. Go ahead.
Oh, no, go ahead. Sorry.
Oh, I was just saying they definitely exist. And so it's probably wise for most pregnant people to stay away from very potent agricultural chemicals. But I think this is also an area of research about these environmental impacts on the pregnant person, the placenta.
All right. I think there's a question on Dan about the relationship of placental infection and the occurrence of hypertensive disease in pregnancy. And I think we've answered it. We've talked about if the infection especially happens in the first trimester and interferes with the point when we're having vascular invasion, then it could lead to that. Can placental tissue be grown outside of the womb?
Yeah, that's a great question.
Placenta.
In terms of research, there are some placenta on a chip models, and there are some placental cells that have been grown in vitro and are used for placenta research. But a whole human placenta, I have not seen grown outside of the womb. That would be very, very helpful. So if someone can invent a way to do that, I think it would help us greatly in our research causes.
Yes, it would be quite nice. Can placental size predict placental insufficiency? We would say that in a placental insufficient placenta, it would tend to be smaller and lower in weight. Would you agree?
Absolutely. And especially relative to the timing during pregnancy at which you measure it and the size of the baby.
Well, the questions are quite a lot. Explanation between malaria causing abortion and miscarriage. I think we've discussed it in terms of your, would you like to summarize how malaria can lead to miscarriage?
Yes, it can. And I think it's probably not the most common cause of abortion or miscarriage, but through inflammation and essentially causing rejection or insufficiency such that the fetus can't survive. I think those would be the main mechanisms.
True. All right. We're running out of time, so I'll try to cover a few more questions. The questions are quite a number. Other than hearing loss, how can one identify CMV in a newborn?
Yeah, so I covered some of the physical signs and symptoms, including jaundice, hepatomegaly, some of the neurologic symptoms, but the diagnosis is made using PCR. So PCR of the urine or the saliva are the common ways. So that's why it's a challenging diagnosis to confirm.
Okay, all right. And I think there are a lot of questions on CMV as well. So for a neonate with jaundice with a positive CMV IgG, is it advised to treat or not, since IgG just shows exposure?
Yeah, generally speaking, this is a complex area, but I would say an IgG test alone should not be your threshold to treat because the IgG could have been maternal. So it could have just crossed the placenta, and I usually wouldn't chalk that up to being the cause of the patient's jaundice. So I would look for other causes.
All right, okay. I think we can take one or two more questions
Sure.
and then we can end there. We have one. Can placental injury determine the difficulty during delivery, like complications of a retained placenta? It's a good
Yeah,
question.
you should take that one, I think.
Yes. So for placental injury, depends on what we're talking about in terms of placental injury, can determine the difficulty and complications of a retained placenta. So when you're saying placental injury, are we talking about like what is it called? Like an insufficient placenta that is injured during delivery, and maybe so if you're talking about retained placenta would be if you're suspicious of a placenta creta syndrome. So if you have a retained placenta, you're trying to remove it as we would manually remove a placenta if it doesn't deliver a certain amount of time, or you've added uterotonics and we're still not able to dispose, then you'd think of a placenta accreta spectrum as opposed to just placental insufficiency. And that would make a very difficult, we may have to go into theater. Let's see. I think one more and then we can end. When placenta previa is taken care of medically, would it have adverse effects nutrition-wise on the newborn?
Yeah, that's a good question. I don't think it would, but I defer to you, Dr. Gutu.
Usually not, because mainly when we're talking about placenta previa, it's low-lying placenta covering the uterine cervix. So generally, if you're not having any forms of bleeding, then that should be okay. It do not cause malnutrition or reduce nutrition on the fetus and cause fetal growth restriction. The challenge is that when you have an acute hemorrhage and have to deliver immediately, but it shouldn't affect cause undernutrition of the fetus. All right. I think we can end there. There are multiple questions, but we've tried to answer as much as we can. Thank you so much for joining us on this webinar. It's been very informative, Dr. Lisa. And I know you have other sessions coming up later on in the year. And we hope to listen to what you're doing in Uganda. And hopefully by that time we'll change our practice in terms of how we view the placenta and look into further research in the same.
Thank you so much for the opportunity and your time.
All right. Thank you so much.
Thank you.
All right.
Yeah,
bye.
thank you. Bye,
Bye.
everyone.
Thank you once again for joining us today. We will be back tomorrow with the session that's posted on the screen. And for those who might be looking for the next sessions that we are holding, I have posted a link for the KNH1 webinar WhatsApp channel. It is posted on the webinar chat. Kindly click on that link and follow us for the latest updates on our events. And we look forward to seeing you tomorrow. Thank you once again for joining us. Do have a wonderful afternoon.
Thank you.
Okay.